It's my privilege to introduce Dr. Luke Putnam. He's an assistant professor of clinical surgery at Keck School of Medicine at USC. He completed his general surgery residency at UC Irvine and was inducted into the Gold Humanist Honor Society for his exemplary and compassionate care. Dr. Putnam then came back to Keck School of Medicine of USC for specialty training in advanced gastrointestinal and minimally invasive surgery, where he's now a full-time faculty member. So during his time at USC, he's demonstrated a strong commitment to teaching and has initiated an oral boards preparatory program called Caliber, which is going to help us examine our candidates tonight. So Caliber is a community of board certified surgeons dedicated to helping recent graduates kind of pass their oral board exams. Program offers on-demand mock orals that you can schedule, expert feedback, video recording reviews, performance metrics, and personalized coaching on how to take the exam. Caliber emphasizes a pretty essential exam taking techniques through a one-on-one or group sessions, focusing on key topics and strategies for success in the oral boards. Our Caliber examiner tonight is Dr. Juliet Ray. She's a board certified colorectal surgeon based in Palm Beach, Florida. She completed her general surgery residency at Jackson Memorial and her colorectal fellowship at NYU Langone. She's established a strong foundation for a surgical career through these two aspects of her training. Now an attending surgeon at HCA Healthcare, Dr. Ray works tirelessly to help prepare the next generation of surgeons through her involvement with Behind the Knife and Caliber. She has been an invaluable member and examiner for Caliber for over a year now, and we're really excited to have her examining with us today. So our examinees are Scarlett Ho and Aaron McAtee. Scarlett Ho has completed her residency at East Carolina University in Greenville, North Carolina, and she's currently pursuing colorectal fellowship at Corewell Health, Beaumont, and Royal Oak. And Erin is a colorectal MIS fellow at UT Houston. She completed her medical school at Alabama College of Osteopathic Medicine and recently completed her general surgery residency at the University of Kentucky. So it's really great to have all of you here, and I'll turn the floor over to you.
Awesome. All right. Well, thank you again so much for having me as in collaboration with Caliber to go through some scenarios today. So, I think one thing that really helps as you're preparing in your last few months before the oral exams is to kind of think of two components to your oral exam. There's the medical knowledge and there's the way that you present yourself and the way that you deliver the information. And so we'll provide feedback the way that Caliber does on those two components, because sometimes you can make up a little in one direction where you're lacking a little in the other direction. And there are a lot of techniques that you have plenty of time to kind of mature over the next few months before your exam. So I think we're starting with Dr. Ho. So I'll give you the first scenario. Okay. And I'm going to time us. So we have about 7 minutes and we'll do feedback at the end and then move forward with the next scenario. So here we go. All right, you have a 6-year who's referred to your office after her primary care notes a calcium level of 10.7. She had additional laboratory work that showed a PTH of 200. She has no other past medical or surgical history and no contributory family history. She has no history of kidney stones, has never had a bone scan, and she doesn't take any medications currently. Her physical exam is completely unremarkable, and she was sent to your office for further management. What is your differential diagnosis at this time, and what additional blood work or confirmatory tests do you need to work this up?
So just to confirm, it sounded like you said she was 62 and she is coming to me with hypercalcemia, but largely asymptomatic with an elevated parathyroid hormone level. And so my initial thoughts are certainly this could be familial hypercalcemic hypocalciuria, but with an elevated parathyroid hormone, I'm also thinking that there's a possibility that the parathyroid is an etiology, so things like parathyroid adenoma or a carcinoma. She certainly, when I see her, I would want to get a history physical confirming. It sounds like that she has a fairly benign history. Likely nothing on exam as well, but certainly I would take care to examine her neck, her thyroid, and her lymph node basins. I would want to make sure I get a full biochemical workup, including a blood count, a metabolic panel. She already had the parathyroid hormone level, but I would also want to check her thyroid hormone levels and thyroid function tests, and if she were amenable, a 24-hour urine collection.
Okay. So her additional blood work reveals normal GFR, normal vitamin D levels, and her 24-hour urinary calcium is 300 a day, 300 milligrams per day. How do you describe what you're going to counsel the patient and what your next steps are? And do you need any further tests to offer management to this patient?
The other thing I would like to check is an ultrasound of her neck as well before I offer any further counseling.
Okay, so you explained to her that you want to perform a few additional tests, including the ultrasound, and you really don't see anything abnormal. The thyroid gland looks okay.
Okay, and we have not yet quite ruled out what is the source of her elevated parathyroid hormone, and certainly nothing stands out in her ultrasound, so I would discuss pursuing sestamibi scan to identify if there's a hot parathyroid.
Okay. Are there any other tests you would want to do to see if she has an indication for surgery?
Let's see. I guess there's the off chance that if she has something in the parathyroid, she may also fall into a genetic syndrome. But it sounded like her family history was largely negative.
Okay. So let's say you do the localizing study with the sestamibi scan and you see something in the right inferior pole of the thyroid. Looks suspicious for an adenoma.
Okay. My thought for a parathyroid adenoma that is producing a primary hyperparathyroidism with a resultant hypercalcemia in a patient who's age 62 is to proceed with a parathyroidectomy.
Okay, can you talk me through the key portions of that procedure?
So certainly under general anesthesia, supine with the neck partially extended, I would use a collar incision or a cochlear incision within a neck fold and dissect down through to the platysma, raise platysmal flaps as well as skin flaps. And then based on the imaging, because my suspicion is that it's on the right side, I would focus on the right side of the thyroid, medialize that thyroid lobe, ligating the middle thyroid vein, and then taking care to identify. Usually, I would presume hot adenoma is slightly enlarged, but a regular parathyroid may appear as small as a rice grain, but it would have a different golden coloration. And so once I identify the parathyroid, I would want to have the OR team help me out with a blood draw, checking the first a baseline parathyroid hormone level, and then upon removing and ligating the vascular pedicle, checking another repeat level at 10, and if needed, at 20 minutes afterwards.
Okay, so you perform this focused parathyroidectomy, your baseline PTH is 450, and you identify the gland, and it does look consistent with the adenoma. So you remove it and you check your levels, and you also do frozen sections and confirm that it's parathyroid tissue. So at 15 minutes, the level is still 200. What's your next step?
So even though 200 is technically still elevated, it has at least dropped by half. So I would want to draw another level 15 minutes later to be sure, but I would not wait to proceed with closing the incision and ensuring hemostasis.
Okay, let's say that the level did not drop appropriately. What would you do at this point?
If it did not drop appropriately, then I would be concerned that there is either another involved parathyroid or perhaps ectopic or supernumerary. So then I would proceed with bilateral exploration, making sure I identify all of the 3 remaining parathyroids, evaluate their appearance, and certainly if they appear enlarged or adenomatous, I would remove them and then recheck a level.
Okay, where are some places you would look if you don't find the glands in the typical location?
Most commonly it's because they are in the typical location, I just haven't looked hard enough. But if they are truly not in a typical location, most commonly they may be next to the esophagus, or I may have to look in the thymic tissue. Those would be my top 2 places.
Okay, so let's say you had been doing your bilateral neck exploration and you find 2 of the other 3 remaining glands and they all look normal. How are you going to proceed? You can't find the last one.
Without identifying all 3, I would be hesitant to remove any normal appearing ones. I think the best course of action would be to actually finish the procedure now and then counsel the patient that in a few months recheck his sestamibi, see if we can identify where the source is.
Okay, thank you. We're going to stop there. So that scenario was just a little bit over the time, maybe 50 seconds over the time that we would have, allowed you. So first of all, excellent work. Breathe. I think that, I would have said that you passed that scenario. In terms of, we'll start with just going through some, specific feedback about the question itself and then some, style stuff. So I think when you're in your very first question, everyone gets like bombarded, especially when they give you a very big opening like this particular question had. And I liked how you did a summary statement to kind of get you and the examiner on the same page. That's a very good strategy, especially as you get lost at various points, throughout. You can kind of do that summary, make sure everyone knows what we're talking about. But I thought yours was like a little long and redundant. So you don't need to repeat everything they said, but you could say, in summary, I have a 60-year-old woman with X, Y, and Z who doesn't have any findings on exam, or, one short or concise statement. But I like that strategy. I just don't think you need to repeat everything, because that first sentence was like a minute and a half and we only have 7 minutes. I looked at the clock and I was like, oh gosh, we're not making it through this scenario. So work on just making that more concise. And then once you go through, your differential, you kind of hit the two main things. It's probably primary hyperparathyroid. You want to rule out the familial syndrome. So you need that 24-hour urine calcium. You mentioned the labs, which is also important to check the GFR. And then don't forget the vitamin D. I don't think you said that one.
Yeah.
And then, at some point you brought up genetic testing, which you really don't need, in a patient like this who's 60 something without a family history. So you knew that. And then at this initial point, you probably don't need imaging either. So you were good, up to this part. And then, once you got to the indications for surgery, there's, asymptomatic indications, and then there's the symptomatic indications. So for asymptomatic indications, in a young patient with an abnormal GFR or a calcium greater than 1 above normal, you can review those. The 24-hour urine calcium also has to be higher than 400. Or with, osteoporosis, osteopenia on a DEXA scan, so the bone density less than -2.5. Or if you have imaging evidence of stones, so you could have mentioned, get a renal ultrasound, or also take a history of neurocognitive symptoms. So that could also be, something that may not be caught on that initial presentation. And then, once you get into, they tell you that the patient is going to surgery, do you need anything else to proceed? I think at this day and age, most people, want to localize it. So I liked your idea of an ultrasound. And if you don't see it on there, you can do a sestamibi scan. So, then you got to the kind of point of the scenario where you're going to the OR, and you used a really good summary statement there. So I have primary hyperparathyroidism with a gland located, in the right inferior. And that was, again, a good, like, okay, now we're all on the same page. We know why we're going to the OR. And then every single surgery procedure that you're going to have to use for this test, you should be able to summarize in like the 5 key steps, which you did pretty well. You kind of threw in like a little, maybe too much detail about the opening and the positioning, but you can kind of narrow that down. And then you did remember a little late about the blood draws, but you want to take your pre-incision, your pre-excision, your 5 minutes, and your 10 minutes. I think you said, well, maybe some people do it a little differently, but 10 and 20, I think you said. There might be some variability on that. So then you move forward with performing your parathyroidectomy. And if your level drops appropriately, you're probably good. If it doesn't, you have to convert to the gland exploration, and you have to know where to look for the, other places where you might find this. So that includes the retropharyngeal and esophageal grooves, the carotid sheath, the thymus. You can use an ultrasound to look in the thyroid. So you were pretty good on that. And then, I think, again, you always keep in the back of your head, this is a test of safety. So if you're not finding what you expect, or, God forbid, you take out 3 glands and your PTH is still not appropriately dropped, then you're going to stop there. And you can say you'll re-image the patient. You don't want to do something that causes them more harm than good. So you were right on that front. So I think that's pretty much the medical knowledge side of the feedback. And then in terms of your presentation, I think you stayed very calm, which was good. You used those summary statements when you got lost to kind of buy yourself time. There were like a few ums. So, I think work on that. And, but I like how you, kind of presented the information in a calm and good paced way. You weren't too slow or too fast. So I think that was excellent. That's all I got, unless anyone else has any other feedback for this scenario. I'm good.
Thank you so much.
And move on to torturing the next victim. Okay, Dr. Is it McAtee? McAtee. Okay, perfect. All right, let's reset the clock here. All right. So you're consulted on a patient in the ER. It's an 80-year-old bedbound nursing home female with severe dementia who's sent to the ER with failure to thrive and lethargy. The patient's nonverbal, and the ER is calling you about a sacral D-cube. The past history is significant for dementia, hypertension, and diabetes. She's no prior surgeries. She's on insulin and metoprolol, and she has no significant social or family history. In the ER, her temperature is 100.5, heart rate 100, blood pressure 90/60, O2 sat 92 on room air. They've placed her on norepi and for the hypotension in the ER. On exam, she's nonverbal, and you see a 10 by 10 centimeter sacral D-cube with undermining, and it looks like it's down to the bone. There's some purulent discharge and a foul odor, and it appears that there's some necrotic tissue as well. What labs and imaging do you request at this time?
Okay, well, I would first request that the emergency department place 2 large bore IVs and administer a 30 cc per kilo bolus of crystalloid to start resuscitating the patient. In terms of lab work, I would get a complete blood count with differential, a common metabolic panel. I'd get a set of coag studies with a PT and INR. I'd also get an arterial blood gas with a lactic acid, and then proceed to go assess the patient. No imaging at this point. I would want to assess the patient first to be able to get a good look at the wound. Would also like to know if there's any family available or has been reached at this time.
Okay, so the BMP shows a bicarb of 18, creatinine 2.5, white blood cell count 15, H&H normal, coags normal, lactate is 3. How are you going to manage this patient? The family is on their way.
Okay, I would be concerned that this patient has a source of sepsis. Most concerning at this time would be for her decubitus ulcer. But upon evaluating the patient, I would be looking for any sort of other etiologies for her sepsis. I know we mentioned she's on room air. So ruling out, I would obtain a chest x-ray to rule out an underlying pneumonia. I'm concerned that the wound tracks to the bone. So I'd go ahead and order a CT abdomen pelvis at this point without contrast, given the extent of her acute kidney injury, just to see the extent of her wound. And then do a fairly thorough physical exam as much as we could on the patient to see if I can't identify the extent of the wound.
Okay, so again, you re-examine the wound and it looks like it's down to bone. You see some necrotic tissue and extensive purulence. The family's now on a flight and you can't reach them. And she's still on pressors after the bolus and resuscitation. You've also started antibiotics.
Okay. Yes, would start antibiotics upon evaluating the patient and seeing signs of sepsis. Blood cultures hopefully drawn prior to administering antibiotics. I'd be concerned that this patient needs urgent source control of her sepsis, and so I would recommend surgical debridement of the wound as urgently as able to obtain operative room availability. Understanding that the family is on the way and I would not necessarily be able to get verbal consent from the patient, but would do it under assumed emergent consent and could do it with the assistance of one of my surgical partners, the anesthesiologist.
Okay, so you're in the OR now and you see large areas of non-viable necrotic tissue and there's some grayish exudate and drainage from this wound, and there's undermining and it tracks towards the right ischiotuberosity.
Okay, I would proceed with debriding any sort of non-viable or tissue or muscle that does not contract on my exam. I would send gram staining cultures from this tissue in order to better tailor antibiotics, ensure that the patient's getting appropriate therapy. Once I reached to the extent of infection, I would be discussing with anesthesia how the patient is doing from a hemodynamic standpoint to see if we would be able to proceed further or whether the patient needs to be taken to the intensive care unit for further resuscitation.
Okay, so what stage, how would you stage this ulcer?
This would be a stage 4 ulcer if it is tracking to the bone and if there's extensive necrotic tissue.
Okay, so the anesthesiologist says that the patient's, been maintaining, they're still on some low dose pressors, but you're able to complete your procedure and transfer the patient back to the ICU after your debridement. How do you manage this wound?
Okay, at this time, I would plan to pack the wound with saline moistened gauze to fill the wound thoroughly with gauze and plan to change it at least once in the ICU, but plan for a return to the operating room in 24 hours for repeat evaluation.
Okay, so you're able to manage the wound. You eventually do a few more debridements, and now it's about 2 weeks later, and the nurses are telling you they just really cannot manage this wound. They're changing the dressings multiple times a day. The patient is incontinent, and they're unable to get good control of the wound care. What can you offer the patient?
Okay, this would be a patient who is elderly, bedbound, unable to care for their wound. I would be concerned that the patient may need fecal diversion in order to properly heal their wound. One thing I'd like to know would be what other steps we've taken outside of just changing the wound, whether the patient has had a rectal tube, a Foley catheter, things to kind of divert stool or urine away from the wound in the interim.
Okay, so they have tried all of that, but they still can't get good control. So you decide to move forward with your procedure. What procedure are you going to perform? And talk me through the key steps of that.
Yeah, I would have a lengthy discussion with the family prior to proceeding to the operating room, just because this would be a palliative procedure in a patient who was in their 80s in the critical care setting. Ensure that they understand this ostomy would likely be permanent for this patient, given her underlying medical comorbidities and functional status. My plan would be to perform a minimally invasive end colostomy for this patient. Plan to enter the abdomen using an optical technique, triangulating my trocars to the descending or sigmoid colon, finding an area of sigmoid colon that appears healthy, transecting this colon with a linear stapler, and then maturing it up to the skin as an end colostomy.
Okay, so you do that, and on post-op day 1, you go to evaluate the patient, and you see that the patient is now on pressors, and the colostomy looks purple and dusky.
Okay. I would be concerned about viability of the ostomy in the setting of vasopressors, but would also want to further investigate why the patient had a sudden decline in their status. So I would repeat a full set of labs, do a thorough physical exam, be most concerned for an intra-abdominal etiology or sepsis. Other thing I would want to investigate is her wound and ensuring that it is clean without other signs of infection.
Okay, the wound looks okay, but you evaluate the ostomy and you do see ischemia, and it looks like it's extending below the level of the fascia.
I would discuss with the patient's family that the patient needs to return to the operating room urgently for a colostomy revision. The hope would be just to resect the portion of the ostomy back to healthy tissue and potentially have to remature versus just debride any necrotic tissue.
Okay, so let's say you eventually get the patient through this and their sacral decube heals over the next year. They're asking about reversal.
Yes, it would be a risk-benefit lengthy conversation with the patient and their family. One thing that concerns me about her ability to have reversal would be her functional status, as she is bedbound. Things that I could do to assess for her candidacy would be a gastrograph and enema to assess how much functional rectum she has remaining. Also do a colonoscopy, one through her proximal colon, as I don't know when the last time she had a colonoscopy was, to ensure she doesn't have any other issue with her colon, and 2, a flexible sigmoidoscopy of her lower rectum to ensure it was healthy. I would ensure the patient has been seen by her cardiologist and her primary care doctor to obtain appropriate risk stratification before an operation, but would thoroughly discuss with the family that given her functional status, her underlying comorbidities, her dementia, I would be concerned for her ability to successfully undergo general anesthesia and recover from another operative intervention.
Okay, thank you. All right, perfect. So that was excellent. We were also just about 1 minute over, but I kind of kept going just to get through some points, but just to keep an idea of what the pace is like. I think we got through the whole scenario, and so you were very good in terms of pace. So to start with the medical knowledge feedback, you definitely, hit all the key points here. So like any case, whether it's a trauma or any patient that, starts in the ER, don't forget those ABCs, which is what you did. You stabilized the patient first and then worked on ordering the labs and, all the other things. I think that you did a good example here of taking the scenario where they leave you. So, this one started, you already had the vitals, you had already had the exam. They're asking you, what do you want to do next? And, you said resuscitate, get the labs, get this. So not every scenario is going to start with the full physical exam and history. They may give you that. So be really cognizant, because I think that can kind of piss the examiners off if you're, wasting their time reiterating something they already said. So you did a great job with that. Another thing is, you paid attention to the proxy. They love these kind of things with anything with like a nursing home patient or, an unconscious patient. And you were good about, asking about that and making sure you had 2 physician consent. So there may be some other underlying themes they're trying to ask you in some questions, whether they're ethical things or, scenarios like this. So again, they're trying to test your ability to be a good, safe, ethical surgeon. So you got that portion as well. When you talked about the resuscitation, I liked how if you want to throw in details, you could have said, I'm going to bolus like 30 cc's per kilogram, or I'm going to bolus with X amount of fluid or this kind of fluid. If you have information to offer, you can do that. But what I also liked about how you answered this question is you only answered what was asked. You didn't like go on long tangents, which I think is a very good, safe strategy, because sometimes that can get you in trouble as well. Other things you could have mentioned, but certainly not, failing points, admit to the ICU right away, place the Foley, make sure you have appropriate IV access. I think you did mention that one. And then the antibiotics, just throw that in early. And then, when we got to the point, you didn't waste time on imaging. You knew the patient had to go straight to the OR, debrided. You talked about serial debridements if necessary, which was good. And you knew the stage of the ulcer, so all excellent. The one kind of key thing to keep in mind with these scenarios is the nutritional status. Try to throw that in if you remember. Very important for these, for the IBD patients, cancer patients, again, just making sure you're, thinking about the comprehensive care of the patient. And then when you got to the point of the colostomy, I really liked how you mentioned you're going to have that thorough conversation with the family, make sure they know it's maybe temporary or permanent. You could have thrown in there ostomy nurse if you wanted extra credit points. Whether you do the loop sigmoid colostomy or the end, I mean, you can make arguments for either. I don't think you need to say I would do this or this. I kind of liked how you picked an answer and you stuck with it, but you should know why you're doing that one if they ask. And then you handled the complication well. You knew that this was an indication to go straight to the OR. There's really no other reason to mess around at this point. But I also liked how you weren't so narrow-minded. You said I'd work up for the full other things of sepsis too, even though, you knew what was going on. So that's great. So yeah, I really don't have anything much to add. When they're talking about the reversal, that might be another good time to mention the nutritional status again. And, you could consider if you need plastic surgery or anything, if it hadn't fully healed, to do a flap. Those would be other options, not in this particular patient, but to deal with sacral decube. So I thought you really answered that one great. Both of these scenarios definitely passed. So good job, guys. All right.
Great.
So do we have time for one more, Jordan?
Yeah, absolutely. It's only 7:30. Scarlett
Oh
is
boy,
off.
we're just zooming right through here.
Yeah.
All right. Then who are we torturing with this one?
You can hit me again. See how much
Okay.
you struggle.
Awesome. Let's just go for it. All right, perfect. So we'll start the timer. So you're seeing a 65-year-old healthy male in your office with a concerning skin lesion. He has a long history of sun exposure. The skin lesion changed recently, though. It used dark brown and now has some irregular and black scattered areas around it. His medical history is notable for hypertension and BPH, but both are well controlled, and he's never had surgery, no allergies. On exam, you see a 1.5 centimeter irregular bordered hyperpigmented skin lesion in the right mid-back. Several areas of the lesion are black, while the rest are sort of darkish brown. What additional workup would you get for this patient?
So I have a 65-year-old gentleman who's with otherwise fairly benign history, who's presenting with a change in a pre-existing skin lesion concerning for malignancy. I would also want to make sure in my exam of the patient to check for any other additional lesions, perform a full skin exam, and also perform a full lymphadenopathy exam. I would want to counsel him that in order to obtain diagnosis, we would need to proceed with some type of tissue biopsy. But I would also want to make sure that we have a basic set of labs, a blood count, a metabolic panel.
Okay, so his labs look good. Tell me how you're going to take the biopsy.
So my preference would be to begin with a wide local excision, because my concern is that if I do something smaller, such as an incisional or a punch biopsy, I may not know the full margin status. And so that's what I would counsel the patient. We can certainly do in the office or in the operating room, but it would be a 2 centimeter margin around the borders of the lesion, and then take through the full thickness of the skin, including the fascia below, obtain hemostasis, and then reapproximate the skin edges. And certainly if the lesion and its margins encompassed a wound that was difficult to close, we may need to do some local advancement flaps.
Okay, so let's say you had started with a biopsy, a punch biopsy, and you knew that this was now a malignant melanoma, 2.7 millimeters deep and non-ulcerated, Clark's level 4 with 5 mitoses. You don't feel any abnormal lymph nodes on exam. What do you do next?
I think you bring up a good point, is that the ability to check the sentinel lymph node is preserved if I don't do the wide local excision at first. With a depth of greater than you said it was 2.7 millimeter deep. So he qualifies for sentinel lymph node testing, especially if he has clinically negative nodes. So then he certainly, with a diagnosis of melanoma, would need the definitive wide local excision in combination with lymph node scintigraphy.
Okay, is there anything you're going to do before you do the procedure? Anything else for staging?
So he would benefit from cross-sectional imaging to evaluate for metastases.
Okay, so you counsel him on your planned procedure. You don't see any metastases. How do you perform this and your plan for the sentinel nodes? Talk me through that.
So the radionuclide would be injected 4 quadrants outside of the lesion prior to surgery, and then he would obtain the actual nuclear study to see if the tracer approaches which nodal basin. And then we would have an idea going to the operating room which nodes we are going to surgically excise to see if they contain disease. Then in the operating room, what I would also do is inject a dye in the same 4 quadrants and then proceed with the wide local excision as I described previously. And then we would approach whichever nodal basin afterwards to obtain nodes that are either or both hot and dye colored.
Okay, so let's say the lymphoscintigraphy showed drainage to both axilla. What sentinel node biopsy or biopsies are you performing?
So I would perform nodal excision from both axilla then. So again, going from one side to the other, making a transverse incision in the axilla, dissecting down to the clavipectoral fascia, and then searching for nodes that are either hot with my radionuclear probe and those that are visibly colored with the dye.
Okay, so you complete the wide excision and bilateral axillary sentinel lymph node biopsies, and you get 3 nodes, 2 from the right and 1 from the left axilla. Both right axillary nodes have metastatic disease without extranodal extension. How do you proceed?
So he has involved nodes, but 3 in total. And so according to historical trials, doing the completion adenectomy would not necessarily benefit his overall survival. So he still would need referral to oncology to begin adjuvant therapy, whether that be immuno or traditional chemotherapy. And then he would need surveillance of his nodal basins with ultrasounds if we choose not to pursue completion lymph node resections.
Okay, is there any particular genetic testing you would be looking for this type of malignancy?
He should undergo at least BRAF testing to see if he benefits from immunotherapy.
Okay, so, and in terms of dealing with the remainder of the lymph node dissection, are you going to offer him that?
Especially with bilateral involvement, I think the quality of life and the side effects of removing entire nodal basins without a survival improvement, it is tough to offer that to him. But certainly if he wished to pursue it, I'd be willing to. I would recommend going instead with regular surveillance.
Okay, and can you give me an example of an adjuvant immune therapy that would be appropriate for this patient?
So if he tests positive, or sorry, depending on his testing, he may benefit from a checkpoint inhibitor such as pembrolizumab or nivolumab.
Okay, and what if he's BRAF positive?
If he's BRAF positive, I'm not quite sure which he would benefit from. I would have to speak with my oncology colleagues.
Okay, so he decides to opt for nodal observation and he started on the immune therapy. How often are you going to surveil him?
So physical exam and ultrasound every 6 months.
Okay, so 8 months later, he comes back to clinic with swollen left axillary lymph nodes. How do you work him up?
So with enlargement, clinically, we would be concerned that they have disease involvement, but we would still need tissue diagnosis. So I would see if radiology colleagues could perform core biopsy of one of the nodes.
Thank you. All right, great. So that was excellent. Again, that was about 1 minute over the allotted time just to kind of keep you, on schedule, but I think you definitely would have passed that as well. Very good, pace on this one. You answered exactly what was asked. You didn't throw in a lot of extra information, which is always a good strategy. And I thought you were very thorough and step-by-step in your workup. So in this one, again, they kind of gave you the whole history and physical exam. So you didn't need to ask any questions and you just used a summary statement. And you then did all the key things. So you confirmed the physical exam, skin check obviously being most important, and nodal exam. And then, I would probably start with a biopsy, especially for a fairly large lesion, because you're going to need such big margins. And
Right.
like you said, it burns your bridge, but I thought that was a really good save. Again, another good strategy, yes, that's a good point. I would have done this because then it saves me the opportunity to do the sentinel node. So I thought you handled that well. And then you complete the staging. Don't forget that part. And then you were right to offer him the wide local excision with the sentinel node biopsy. And you had mentioned it earlier, if it's a really big lesion or some more sensitive location of the body, that you may need a flap coverage. So you could be cognizant of that if you need to involve, plastic surgery or do it in a stage fashion. And then I thought you were, appropriate on your description of the procedure, the lymphoscintigraphy and the blue dye, and how you were going to inject those. And then, your wide excision you had mentioned earlier with the 2 centimeter margins. and then you knew how to handle the bilateral lymph nodes, then you threw in some knowledge. That's great. It doesn't, benefit to kind of do the excision, and that they're going to benefit from adjuvant therapy. And I was just being mean. I don't know that they would ask you on the general surgery the level of that, but I looked it up before this practice because I clearly don't remember that. But yeah, so pembrolizumab and then dabrafenib if it's, BRAF positive, and you need to test for BRAF. So that's great. I think in most cancers now we're moving towards targeted therapy. So it might be reasonable that they would ask you some basics for, general colorectal or other cancers. So you knew about their surveillance, every 4 to 6 months, of course, the skin checks, nodal exams, labs. And then when he comes back with the, probably a sign of recurrence, you need to biopsy it. So yeah, I thought that question was great. You mentioned, discussing with your oncology colleagues. I would throw in the word multidisciplinary tumor board with every single cancer case, because that, obviously know to do that, but it sounds, fancy and thorough. So that's awesome. So great job. I think maybe Jordan, should we take like maybe 2 minutes to talk about some general strategies? Do we have a little time?
Yeah, we do.
Okay.
Maybe one question for our listeners is, I think it's a little bit confusing when you actually choose to stage melanoma. Maybe you could go through that just a little bit.
Yeah, I'm definitely not the expert on this. And I think also I would say that many of your examiners will likely be examining outside of their field of primary expertise. So the level may not be so advanced and they might not ask you on all the nitty gritty. But I think in terms of if they have positive lymph nodes, that might be a good time to, do that, because then they might have, especially you can think about like the brain or other areas where things, may metastasize. Another thing is, in this question in the caliber notes, they brought up to think about other screening. So, if you're working up a patient for one cancer, I would maybe throw in that they're up to date on their colonoscopy, their mammogram, anything else, because, it might point you in a direction of a syndrome, especially in a young patient. But yeah, I don't honestly know the nitty gritty of criteria for full staging for that.
All right. Yeah, let's go through strategy. I think you did a good job with Aaron and Scarlett talking about strategy, but maybe just a little bit of general guidelines would be helpful for our listeners.
Yeah. So, I think that if you can, it kind of depends on your stage in your preparation. So for you guys that I know are taking the test in November, you have time to work on both the medical knowledge and the presentation side of things. But one thing I always thought about, because I would get very stressed in doing these exams, is, control the things you can control. So you can sit up, you can keep your hands not moving. You can try to avoid saying, so you can focus on answering the question that they're asking without going on long tangents that may be annoying or distracting to examiners. So those kind of things, now that you're doing a lot of oral practice, you should focus on, mimicking in real life. And also whenever someone's examining you, have them time you and keep you on track on the time, so you have an idea of how long the scenario will actually be. I think those things are kind of modifiable risk factors, how you present yourself. Another thing, I was going to bring up is, again, those summary statements, which you guys did really well. Don't do them every 5 minutes, but if you're getting lost in a scenario, or sometimes you think you're answering correctly, but the examiner's actually on a totally different track, it works really well to make sure that you're both on the same page. So maybe 1 or 2 times, bring it back. Oh, I have this patient with this problem. My next step is this. And that's a very good, kind of way to focus on that. Another thing to keep in mind is, on these tests, you are in the world's most perfect hospital that has unlimited resources and all your friends are available. So, when you practice, don't say, oh, if I had IR, I would ask them to drain this abscess. Or if I had urology, I would ask them to put stents in. Just say what you would do in the perfect scenario. They may tell you that person's not available and you need to go to plan B, but, I think it's kind of distracting. Oh, if I could get this, I would do that. Just say what you would do in the ideal world. I think that will get you somewhere. And then also, if you don't know something, I like how, Dr. Ho answered this. She said, I would review this with my oncology colleagues. I mean, yes, you're not going to know everything. We don't know everything in real life, even in our own specialties, and we have to ask for help. So, again, I think if you think about the core principles of what this test is asking, which is that, are you competent? Are you safe? Are you not arrogant? That will get you very far, and it sometimes does overcome, problems that you may have when you have a little mental block or you just don't know a particular fact.
All right. Well, thank you so much, Dr. Ray. I appreciate you taking the time. We can put some more information out just as a summary about Caliber if anyone's interested in it. And, hopefully our listeners learned a little bit about strategy and some general test taking guidelines for the oral boards. Good luck to everybody who's taking it in November. Well, at least we don't have to go to a hotel room in Chicago.
Yes, good luck. think you guys are both going to do great. Very impressive.
Bye, everybody.